Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. That email will not include the presentation. It is now my pleasure to introduce today's presenters. Dr. Benedict Evans. Ben is a knowledge expert and interim VP of Medical Affairs at Objective Health. Prior to joining Objective Health, he worked in the London office of McKinsey Company. He joined the firm in the spring of 2011 and has served a range of healthcare payers and providers through strategic, operational, and finance-based engagements across Europe and the U.S. Prior to joining McKinsey, Ben was a practicing physician working as an orthopedic specialty registrar in London. He qualified from University of College Medical School in 2006 and attained membership of the Royal College of Surgeons of England in 2009. Dr. Eric Flyckt is a Director of Client Analytics responsible for leading the team that delivers products in the company's Objective Solutions and Objective Answers catalog. Throughout his career, Eric has pursued a strong interest in the application of data to improve the quality and efficiency of healthcare delivery. Prior to joining Objective Health, Eric spent 6 years as a consultant with McKinsey, serving clients across the healthcare spectrum in North America and Europe. His clients include large health systems and academic medical systems, as well as companies in the pharmaceutical, medical device, and health insurance industries. His particular focus was on client projects dealing with strategy and clinical operations. Eric holds an MD from Stanford University School of Medicine with research interests in neuroscience. He earned a BS in Biological and Cognitive Sciences and a BSBA in Finance and Marketing from the University of Denver, where he graduated Phi Beta Kappa. James Stanford is a client service executive for Objective Health. With more than a decade of experience serving organizations across the healthcare sector, James helps to orchestrate the full range of Objective Health's product and services to ensure that clients achieve their goals. James' recent work with hospitals include a comprehensive performance transformation engagement for a multi-hospital system, accelerated margin improvement programs, population health management, capability building, and shared service business building for large independent hospitals and health systems. His experience in other healthcare industries include designing and launching a virtual integrated delivery network for a health plan, creating a new physician reimbursement model for a regional payer, and developing patient engagement programs for a national retail pharmacy. Prior to joining McKinsey in 2007, James was a director of the advisory board Academies. He earned an MBA in healthcare management from the Wharton School at the University of Pennsylvania and a BA from Princeton University. It is now my pleasure to turn the floor over to Mr. Stanford to begin today's presentation.
Thank you so much, and thanks to everyone for joining. On behalf of my colleagues, we're really excited to be speaking with you today about managing unwarranted clinical variation. And so to jump right in, let's start with an interactive poll. And Kathy, if you wouldn't mind turning to that slide, please. Got a question for you. So first of all, how much effort does your hospital or health system put into reducing clinical variation compared to 2 to 3 years ago? Is it more effort? Is it about the same? Or is it less? And so what I'd like you to do is on this, this poll, please just indicate whether it's more effort, about the same, or less than 2 to 3 years ago. All right, so as we're getting results, it seems like it will take about 15 more seconds. Strong bias towards either more effort or about the same. Very few showing less effort. This is not surprising. Got about 2/3 of the vote in, so we'll close it down in about 5 more seconds. All right. Well, let's cap it off there. I think we've got a good sample of the group, and you know, as we might expect, there's an awful lot of focus on this topic, and most of the organizations, at least that are on this call, are spending more effort than they had been, or at least they're focused on it as they were before. Might be interested in the question and answer to hear about those groups that are spending less than before. Maybe they've got it, they've cracked the nut, and they've got some insight for us. All right, so let's talk a bit about why health systems might be spending more time on reducing unwarranted clinical variation. So next slide, please, Kathy. So to start with the obvious, the healthcare industry faces unprecedented change. Well, everyone knows this, but to some extent it still hasn't really sunk in for everybody. And you look at all the components on this page, they're in flux, they're dynamic, they're changes that affect each other. It's the textbook definition of complexity. You know, I was listening to stock analysts who are still saying that some of the publicly traded health systems are going to benefit from the new access made possible from reform, and you know, that might be true over the next couple of years. But if reimbursements grow at the rates that are specified in the law, all providers will have to reach unprecedented levels of productivity. Those aren't my words, by the way. Those are straight from the introduction to the Medicare Trust Fund report that came out a year ago. So the trustees believe that surviving under the new reimbursement formula, and I quote from their report, while plausible, will depend on the achievement of unprecedented improvements in healthcare provider productivity, unquote. Think about that. Hospitals today are constantly benchmarking themselves against each other, but the trustees are saying that benchmarking is useless because no one today is productive enough for the future. Next slide, please. So a quick reminder about what's driving the changes to reimbursement. It's that basic math problem about our government's ability to cover all of its costs. So right now, as you've heard, healthcare makes up almost 18% of the economy. That could keep accelerating upward, except that federal revenues, reflected by the black line, are not expected to keep up at all with its obligations. And in response, the government, through the Affordable Care Act, is trying to bend at least the Medicare cost curve by reducing the growth rate in payments to providers. And whereas Medicare here is shown growing well above inflation or CPI, the ACA insists that by 2016, Medicare growth rates would actually be lower than CPI growth. So this is the fundamental equation that will lead to the productivity imperative. Next slide, please. And of course, it can't just be about cost, right? The other side of the value equation is quality. And CMS is putting inpatient reimbursement at risk based on quality metrics such as value-based purchasing, readmissions penalties, and hospital-acquired conditions. And note that each of these are about comparing hospitals against each other. So it's not good enough to simply improve on quality and patient experience. Hospitals must improve faster than the national average to avoid penalties and to earn incentives. Next slide, please. And so, with the ACA addressing both quality and cost, providers will increasingly be asked about their value equation. How are they maximizing quality while minimizing costs? And while the current performance levers won't go away, you know, people will still use cost benchmarks. They must increase patient throughput through hospitals. They must reduce PSM costs, and they must standardize processes as much as possible. But we're already seeing significant increases in a new set of activities, like maintaining wellness, avoiding hospitalizations, ensuring patients go to the right site of care, and, as is the topic of this webinar, identifying and reducing unwarranted clinical variation. So clinical variation in the past has focused on supply selection, for example. While this still may be important, there's much more ground to dig in, as we will discuss today. So next slide, please. When it comes to pulling those value levers, health systems and clinicians will need to work in a much more coordinated and consistent ways to manage a patient's treatment, whether it's having clear decision-making protocols around whether and where to treat a patient, which treatments to use, how much to use, and how to manage the discharge process. Each of these is an area where providers are focusing today in a way they didn't 5 years ago. And we will spend the rest of this webinar describing successful approaches to these opportunities. All right, next slide, please, and I'll turn it over to my colleague, Dr. Evans.
Thanks, James. And over the next section, I'll be taking you through some of the analysis that we do in the clinical variation work to really work out what the opportunity to drive improvement around clinical variation is. If we turn to the next slide, we will start with another interactive poll. And here the question is, where have you found the greatest level of opportunity to reduce variation? And the options are surgery, medicine, or maternity and pediatric medicine. So I will give you around 30 seconds just to answer that, and then we'll move on. So we have about half a vote through so far. And right now we're seeing a slight preponderance for surgery over medicine, with maternity and pediatric medicine being a much lower focus when it comes to finding the opportunity to reduce variation. Okay, so we have about 2/3 through now, so we'll come back to the presentation. And as you can see, it's pretty evenly split between surgery and medicine. And I would say that's something that we often see in providers that we work with. I would say that the levels of variation are kind of similar between the two areas, but the drivers are slightly different. So around surgery, you'll see more variation driven by clinical products. And then around medicine, the focus will be more on length of stay and disease protocols and protocols around discharges. So if we move on to the next slide. As James has pointed out, the evaluation of clinical variation focuses on the interface between cost and quality, the value equation. And when we think about variation, we want to make the distinction between warranted and unwarranted variation. There will always be a portion of variation that is completely warranted. For example, when you have two patients being treated for the same condition who have different ages, comorbidities, and disease courses. For this analysis, we really want to focus on the unwarranted variation side. And on the right side of this page, you can see examples of some of the questions that we're aiming to address in the work we do around surgeon supply choices, treatment protocols, and resource utilization. Next slide, please. So as I said, we distinguish between warranted and unwarranted variation. And unwarranted variation falls into three broad categories. Underuse, where poor planning and miscommunication can lead to insufficient use of effective care. Misuse, where lack of or poorly adhered to clinical protocols lead to, for example, inappropriate prescribing and thus improperly utilized care. And overuse, particularly with regard to insufficient resources around community provisions for the chronically ill, with resulting inappropriate use of acute care resources and significantly higher costs. Next slide, please. Now, we approach the evaluation of the extent of unwarranted clinical variation that exists at a particular provider from two perspectives. The top-down perspective is based on McKinsey's experience of working with providers in the US and internationally, and says that there will always be specific areas that demonstrate significant unwarranted variation, and therefore should be prioritized in order to drive savings and quality improvements. Examples of these high-level levers include consolidation and standardization of supply usage, and physician preference cards in the OR and cath labs, reduction of length of stay through the combination of evidence-based disease protocols and floor-specific protocols such as IV to PO med conversion, extubation guidelines, and central line protocols. And finally, appropriate resource utilization, including lab tests, CT scans, and antibiotic and blood stewardship. To estimate the improvement opportunity in these areas, we take a bottom-up approach by examining the cost of variability at the DRG level across the hospital, zooming in on high variability areas, for example, specific DRGs, floors, or departments, and rapidly moving to understand what is driving that variability. In parallel, we'll interview key stakeholders in areas like the OR, cath lab, and floors to gain an understanding of where performance is strong and where systems and processes can be improved. And based on the outputs of this analysis, the interviews, and also ongoing conversations with physicians, the aim is to co-develop a group of DRG, floor, or department-specific initiatives for physician leaders to focus on in order to drive improvement. And in the next few pages, I'll take you through this process for some high variability DRGs. Next slide, please. We start by estimating the cost of variation across the organization, focusing on inpatient cases. As shown in the chart on the left-hand side of this page, for each DRG, we compare the average cost per case by physician across the most recent 12-month period. We then derive a cost of variation estimation by calculating the predicted savings if all physicians within a specific DRG came down to the same average cost as the lowest cost physician, as shown in the middle chart. Finally, we'll add the cost of variation estimates across DRGs to reach an overall cost of variation figure. And this can be seen on the right side of the page. And it should be noted at this stage we're still focusing on both warranted and unwarranted variation. Next slide, please. The outputs of this process are shown here, where we have the cumulative cost of variation across DRGs in the organization on the chart of the left-hand side of the page, and some of the highest variability DRGs in the organization on the right-hand side. And once we have these outputs, we can really cut the data in multiple ways to look at a single DRG, a floor, or a department, to understand the level of variability that exists, and so get a feel for how improvement work should be planned. Next slide, please. Following this, the next step is to examine a subset of DRGs that have the highest level of variability and thus potential saving opportunity, and aim to answer three questions. Is the clinical variation unwarranted? i.e., are there any factors contributing to a level of potentially warranted variation, such as different ICD-9 codes within a DRG, or a broad case mix within the patient sample? What are the drivers of this variation? Here we're looking at specific cost categories such as lab tests, drugs, clinical products. And finally, what is the potential impact of addressing the unwarranted variation? Move on to the next slide, please. In the next few pages, we focus on a client example for DRG 470, which is major joint replacement. And as you'll see, the upcoming slides demonstrate that in answer to the aforementioned questions, for DRG 470, a significant component of variation is likely unwarranted, although ICD-9 codes do account for some of this and actually give a level of variation that is warranted. And clinical products are the main drivers of variation, and there is a significant saving opportunity in driving greater standardization across clinical products. And specifically for something like 470, we'll be looking at implants here. Next slide, please. So first of all, we examine the potential cost variation driven by ICD-9 codes across physicians. And you can see that within DRG 470, part of the cost variability is driven by the fact that a large proportion of physicians are doing both total knee procedures, which are highlighted here in orange, and total hip procedures, highlighted in green. We are excluding revision cases and are only focusing on cases without major complications. There should not be any major clinically warranted reason for significant cost variation going on. So from here, we'll now exclude the total hip replacement data and deal with that later, and focus only on total knee replacements. Next slide, please. So within total knee replacements, we now look at the breakdown of each physician's average variable costs over the year, And as you can see, physicians are on the y-axis of the chart, with the cost categories within average costs are delineated by their color on the x-axis. And clinical products, which are in orange, are the clear major driver of variability between physicians. Next slide, please. So at this point, we double-click on clinical products and estimate the potential saving opportunity if all physicians above a certain level of average variable clinical product costs came down to a target physician's figures. In this case, physician number 8 with an average cost of $3,700 within clinical products. The whole approach, including setting a target, is done in conjunction with physicians within the orthopedic department to ensure it's a realistic, practical target to go after. This analysis demonstrates that, assuming all physicians successfully reduce their clinical products costs down to the target, there will be a potential 1.1 million saving in total knee replacement procedures. Next slide, please. And so finally, as you can see, for this particular client, the successful capture of the saving opportunity would have a significant potential impact on the overall profitability of DRG 470 cases. So I'll now hand over to Eric to talk a bit about how we go about implementing change.
Right, next slide, please. And again, next slide. So this section is really all about capturing the value that you've identified. So coming out of this previous discussion, you should have been able to identify a set of opportunities that have real value associated with them. The question now is, in your experience, how difficult is it to go after these types of opportunities as compared to some of the more traditional levers that you may have gone after in the past? The poll is open, and about a quarter of the vote is in, so we'll leave it open for about another 20 seconds. All right. If we close this and show the results. So a small number find that these are easy opportunities to go after. A clear majority feel that it is much more difficult than other opportunities. About almost 3 times as many as feel that it's about the same. So this is quite typical in our experience working with clients as well. Many clients feel that in hospital health systems find this a particularly challenging set of opportunities to go after. I think there's a number of reasons for this. First of all, it's a newer area, and many hospitals don't really have a lot of experience going after these types of opportunities. I think, in addition, there's a particular set of challenges or issues that you face going after clinical variation that you don't in other areas. And if we go to the next slide, we can talk through some of those. The first, there's really 4 elements that need to be in place in order for you to successfully capture opportunities in clinical variation. And this is a little bit different than, some of these are a little bit different than you'd find in other areas. The first and probably biggest characteristically different thing is the importance of clinical engagement. It's really important to have physicians that not only lead these kinds of engagements and put their support and weight behind them, but also ultimately what you're trying to do is change the behaviors of large groups of people across a large organization, often at the point of care. So these are decisions that are being made day to day on the fly, and you can only change those behaviors by having physicians and clinical staff brought in both to what you're trying to accomplish and the approach that you're taking to that. And that in itself is a huge challenge. The second area where some of these types of initiatives fall down is in terms of the supporting resources that are required. Obviously, any engagement requires resources, but these types of issues tend to be more complicated and involve a larger number of people. What we hear is that often you don't have the right people, you don't have enough time, and you don't necessarily have enough knowledge among your clinical staff or the folks that you're tasking with going after these opportunities to get the job done right. And so making sure that you address each of those issues is going to be really important. The third area is really just in the change management process itself. Again, we're talking about implementing change often across an organization with many, many different stakeholders. And as it is, most change initiatives fail. In this situation, you're actually more likely to fail than in others. So a clear understanding of what it takes to manage change successfully is very important. And it affects how your teams, the groups that are going after these initiatives, need to set up their pilots, need to set up their projects, and the steps that they take to support those projects throughout both the design and the implementation phase. The final thing that's absolutely necessary is obviously the ability to analyze and track your performance. So we've shown you some of the analytical capabilities that are important in identifying opportunities. Similar skills or capabilities are required as the team designs their initiative, and clinicians in particular are very comfortable getting stuck into the data and actually often feel a need to it. It's very difficult to get clinicians brought into an effort without good data. And it's even more difficult to show success and sustain your effort if you're not able to prove that what you're doing is having an impact on quality, on cost, on your patients, on workflow. So the ability to analyze and subsequently track your performance is absolutely essential. And as we work with clients, we regularly hear of initiatives falling down at each of these points. So now what I'd like to do is run through each of these in a little bit more detail and mention a couple of things that are going to be practical steps that you can take at each point. So if we go to the next slide, please. So the first area we'll focus on is clinical engagement. Really, this is all about sharing the data and the rationale with clinical staff. You need to share the information so that you can get their buy-in. People need to understand why we're doing this and what's in it for them and their patients. And we also need to give them a clear role in the initiative. And that role may be to lead the team, to help design, to communicate with other people, to gather input, or even just to try something differently than they currently do things. We find that the best way to do this is to be quite rigorous in terms of the materials, the content that you share. So you have to be quite thoughtful about what you bring to physicians, especially around the data, and how you prove the case to them. And this is helpful both as you engage senior clinical leaders that you think of as the sponsors or the folks that are going to lead the effort. But it's also a very helpful tool for them to engage their colleagues and stakeholders that they're trying to engage in the process. And ultimately, it takes not just leaders, but broad engagement of the clinical staff across the organization to go after these kinds of things. To go to the next page, please. So next, we'll focus on the supplies and resources that are required for a team. As I mentioned before, this is about having the right people with enough time and the knowledge to go after these kinds of opportunities. The right people is really about allocating the team and getting the team, a team of people that have the knowledge needed to guide the design phase of this and to bring this knowledge or this initiative to their colleagues. Often that means that you're going to have people at very different levels within the organization working together. Obviously, if you're, this initiative example is all about hips and knees, and having orthopedic surgeons involved in this effort is going to be essential. But also nurses, OR managers, surgical techs will be important as well. The other component to this is having someone who's dedicated to and has the skills to provide analytical support. So there's a lot of legwork that needs to go on in these teams, and someone who can run the analysis easily, and it can be either the decision support analyst or a nurse who's been trained in this area, is absolutely essential. Similarly, as soon as you get into any of these clinical areas, having someone on the team that has the time and capacity to review clinical literature, as an example, is absolutely essential as well. And being able to collect the appropriate clinical literature, distill down the main points, and share that in a format with the rest of the group so that decisions can be made quickly. The time issue is another major problem. The first thing to realize is you're going after large opportunities, and therefore it's worthwhile actually investing people's time in this. And that can be administrative time for clinical leaders, but it also needs to be percentage of time for other staff. It's sad to see projects like this fail because a hospital isn't willing to allocate a small fraction of a nurse's time to get this done right. The final sort of piece on the time, though, is that even with allocating of time, the physicians' especially time, and surgeons' time in particular, is very precious, and they're loath to waste it sitting in meetings. So making sure that you make very effective and efficient use of time in those meetings and structure them really around making decisions as opposed to having long discussions is absolutely essential. And those are points of sort of meeting hygiene that in some ways are very, very simple. But without them, these processes can run out of control and lose all momentum. So it's very important to keep that in mind. And often a team leader, whether it's a project leader like a nurse, really needs to be careful in how they structure the agendas and the meetings and the tones of these conversations, so that you clearly make progress week by week. If we go to the next slide, please. So as you think about the 3 points I made, the right people with enough time and knowledge, the next section about this is really all about the knowledge, right? In many cases, in fact in all cases, there's someone who's done something like this in the past, either within your organization or elsewhere. And it's very important that you try to connect your people with folks that have an understanding of how to build these initiatives. And that can mean putting them in touch with other facilities or other folks in your organization that have experience in these areas. What we're looking at here again is a device standardization example. And the first thing that people need to understand is just what are the typical initiatives that can be helpful, and what is it that you can go after in order to have an impact here. So standardizing your device options is clearly one, but also making sure that you match demand, which can actually be an even more powerful lever than just standardizing the options, is another. If we go on to the next page, you also need a deep understanding of what's going to drive the behavior change. So in the case of device standardization, there's actually some very good reasons why surgeons use the products that they use. There's often data and literature to support their choices. There's specific product attributes that they know and they like. And then there's an element of personal familiarity. It's a device that they've trained with. They have a relationship with the device rep, and they know the company that they're working with very well. If you're going to try to affect something like device standardization, you really need to have an understanding of these kinds of factors and be able to bring supporting levers to address these. So for personal familiarity, for example, you really need to invest in training sessions so that the surgeons can familiarize themselves with the new devices. You also need to provide training to support staff, because without that, they're not going to be able to use the new devices in the OR well. And you need to start bringing in a knowledgeable and trusted representative for the new devices as well to support that learning. So these are examples of things that, without which, if you're trying to build this from scratch, your team might well miss. And connecting them with folks that have done this in the past can be very helpful. So go to the next slide, please. So change management is really the next big topic. This is really all about changing mindsets and behaviors. And as I mentioned before, many of these clinical variation initiatives are looking to change the behaviors of people at the front line in the decisions that they're making while delivering care. And that's a very difficult thing to do. there's some basic principles that underlie when people will change their behaviors. And there's really 4 listed out here that are the most important. So one is, I will change my behavior when I know what is expected of me. I agree with it, and I think it's meaningful. And the key one there is really the meaningful one. Often we're very good at articulating sort of the logical case for change, but you really have to understand each individual's need, or what gives them meaning in their role to affect their behavior. So just to be provocative, if you set up a device implant cost and made it implant standardization effort and made it only about cost, that's not going to have any meaning to many people. Surgeons may not be particularly concerned about cost. What they care about is the outcomes for their patients, and they have to be convinced that that's meaningful as well. And that is an impact of this kind of project. The second issue here is developing the talents and skills, and this is really about providing the training to support the effort that you have in mind. As I mentioned earlier, if you're expecting a surgeon to change their device, you have to provide them with the training to do that. Similarly, if you're going to put in place a disease-specific protocol, that effort is going to fail if people don't know how to enter that order, access that order system on the computer. So there's some very simple things that can get overlooked in change management here. The third area is role modeling. We are very social creatures, and we respond very well to seeing superiors and peers and our team members behaving in a particular way. So often we know who the role models are in our organization. Where we often fall down here is in approaching them and asking them to do something different. So if you know that there are folks that are going to be influential, and it can be folks in senior positions, it can be very informal leaders that exist within the organization, making that person a sponsor, making that person a champion for change can be very effective in supporting your initiatives. And that's something that doesn't take much effort necessarily, but it does take some thought and planning as folks are rolling out these kinds of projects. The final area that supports behavioral change is reinforcing mechanisms. And often this is thought of as primarily being the metrics that measure success, but it actually goes beyond that. It's really about putting in place processes or systems that make it easy to make the right behavioral change and make it difficult to do things the wrong way. So an example of that might be making something a default option or a default choice and making it difficult to do something that's inappropriate. One example of this is in blood stewardship, where often people have developed very complicated protocols to support blood management. But because they're so complicated, it's actually very difficult for people to follow them. A mechanism or structure that you can put in place is a blood team. So anytime an order for blood is put in, the blood team goes in, reviews that order, makes sure that it's appropriate, and then oversees the administration of that product. So with that, let's move to the next slide. So the final area is all about assessing and measuring the impact of the projects that you have. It's very difficult, as I mentioned earlier, to sustain change without being able to prove that you're having the effect that you want. This slide shows some specific targets that are set and tracked and reported on an ongoing basis for 3 particular initiatives, one around blood product utilization, one around extubation protocols, and one around joints order sets aimed at discharge processes. And as you can see, we track a baseline. There's an assessment of the impact during the pilot phase, and there's both a short-term and a long-term target that's set. And each of these elements is important in demonstrating the effect that you're having and the success of the initiative. The final thing I'll say is that a lot of these initiatives need to be reactive, right? So that in initial phases, you're putting together pilots Throughout the process, you're looking to engage physicians to give feedback and to improve the results as you measure them over time. So, in summary, you're looking at strong clinical engagement with teams that are well supported, putting in place the change management processes to support these efforts, and consistently measuring the impact of their projects. And we found that with these 4 elements in place, hospitals can be very successful addressing some of these more challenging topics within clinical variation. So with that, let me pause and see if there are any questions from the group.
Okay, thank you, James, Ben, and Eric, for a very informative and enjoyable presentation. We're now going to begin the Q&A portion of the program, and as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll attempt to answer as many questions as we can during the time we have for Q&A, and our presenters will follow up on questions they do not have the opportunity to address today. I just want to draw your attention to the contact information you see on the screen. You can visit www.objectivehealth.com and for more information about Objective Health. Now we're going to start with the first question. This question is for Ben. And Ben, how do outcomes play into the analysis? How are PATNet comorbidities still leveraged to fit into standards?
Okay, so I guess in terms of the comorbidity side, to begin with, as I understand the question, I guess it's how do comorbidities fit into the analysis that we're doing. And I would say that the DRG analysis that we do, and I've demonstrated today, is a pretty standardized set of outputs. What we'll do following that, and following discussion with physicians and other leaders within an organization, is talk about specific bespoke analyses that will further help them understand how capturable certain opportunities are. And one of these is to look at specifically APR DRGs and actually have basically a hierarchy analysis which allows us to establish within a particular DRG across patients and across physicians what their average comorbidity rating is, if you like. And so we can use that then to make a more informed decision about, for example, whether a particular physician who has a comorbidity rating across the year of X is the right one to target versus another physician. In terms of the first part around the outcomes, I would say across these areas, and I think particularly on the medical side, when you focus on adhering to best practice protocols, standardizing care, you're going to have a significant impact, particularly around length of stay, readmission rates, on patient outcomes. And so it's key, and I guess Eric touched upon this, as you go forward following the analysis done and an initiative is chosen, to actually track your performance over a period and focus on not just kind of financial metrics in terms of how much you're saving, but equally how are readmission rates trending based on the work that you're doing, what are happening to infection rates, what is happening to length of stay, and other outcomes measures.
Okay, thank you. This next question is for Eric. How do you account for quality? The lowest cost physician may not provide the best quality, and does cost extend beyond the acute care stay?
So on the quality front, so two parts of that question. If you actually look at the differences in outcomes for a particular group of physicians, typically at the DRG level within a system, it's hard to quantitatively assess the differences in quality. What we tend to have is a more qualitative discussion about which physicians should we be targeting and modeling our behavior on. So this is where sort of you walk away from the analysis a little bit and you actually have conversations with physicians in the department. If we're trying to emulate a physician in terms of the device choices that they're making, as an example, it doesn't make sense to emulate a physician who isn't respected by their peers or doesn't seem to be seen as the highest quality physician in the group. So that's, I think you really move into some sort of qualitative sides of things there. As far as costs on the outpatient side, there we're really limited by the hospital's own data systems. So when possible, you can certainly look at either the hospital's own physicians that they have serving patients in the outpatient setting, but often some or all of our records are missing from that. So the short answer is it is sometimes possible, but sometimes data in the current state doesn't allow us to do those things.
Thank you. This next question is for you as well. What is the incentive for the physician to participate on this team?
So the incentive to participate on this team is either based on, well, it really has to be based on them being bought in and thinking this is something important, right? So if you can't convince the physician that this is important and worth them spending their time on it, then it doesn't really matter that it's a portion of the allocated administrative time or anything like that. So in many cases, the value from this is that they believe that it's going to be better for the quality of care for the patients, or it's going to save money for their departments, or that some sort of financial quality or workflow impact is actually substantial and important enough to focus effort on. It's hard to corral physicians or force them into this. I would say, though, that organizations that have aligned financial incentives, and particularly if you can think of examples of orthopedic hospitals, specialty hospitals, where the costs directly affect the physicians, frankly, it's easier to get people on board with efforts like this. So, but even there, I think it's the important thing is that the overall impact is valued by the physician.
Okay, great. Eric, you commented that most change transformation fails. What is your experience regarding success/failure in clinical variation change management?
Yeah, so the statistic on most change efforts failed comes from a report that McKinsey put out that was actually across industries. So this is certainly not unique to healthcare, and I think it was something on the order of about 60% of efforts fail. But
even more?
Even more? All right, 70%. 70% of change efforts fail. In clinical variation, the experience that I've heard from hospitals in tackling this on their own is certainly well north of that. When my teams have come in on these kinds of efforts and we've observed, either at McKinsey working with clients or Objective Health, I've struggled to put a number on it, but with sustained effort and let me think back. I'm sort of putting a ballpark in. I would say, our success rate may be 50 to 75% sustained effort, where it's higher in the initial phases, and then the question is, how well do you support it longer term? But there's a clear difference in the success rates with these types of approaches than without.
Okay, thank you. This question is for Ben. What is Objective Health's role in these initiatives?
So we have, I guess, different levels of support that we can offer organizations as they go through clinical variation management and implementation. I guess, first part of that is what we've just taken you through, is really doing the analyses and working out what the opportunities are, and then working with physicians to define specific initiatives that they should work on to take forward, and actually helping them in the process of building teams and helping them based on our experience of what works well around building successful improvement teams. Following on from that, we can continue to support hospitals through that kind of change process. And we would do that in a number of ways. We would standardly offer a workshop where we discuss the outputs of our analysis and the initiatives that we've decided upon with the physician and leadership teams of the hospital. Beyond that, we can focus on actually leading workshops around change management to ensure this kind of change approach is actually sustained over the long period. And we can also work with specific kind of project management teams over a longer period of time, providing them with either the data and the analytics, the evidence bases that they might need to actually create kind of a change narrative story across an organization, and actually to drive that home with the latest literature, and ultimately help them in terms of actually tracking that change, particularly around developing kind of clinical variation scorecards that allow you to really evaluate how you're improving from kind of your baseline rate at present.
All right, thank you. This next question is a long question, I believe, for Eric. In your experience, is it better to ask a strong project team to work on multiple projects in series, say first standardizing device usage in the OR, then standardizing instrument trays and so forth, or rather to form different teams in a different clinical unit for the next project? And then on the one hand, a strong team can continue the learning and change process effectively, but on the other hand, I would be concerned about change fatigue and would want to spread transformation efforts.
Yeah, I mean, that sounds, it's a good question and a reasonable sort of balance that you're trying to strike there. When we approach this, we try to have a relatively narrow set of focus initially, especially if an organization hasn't done this before and hasn't done this before successfully. And what we'll do is pick sort of 2 or 3 areas, often trying to find something that the organization feels it can successfully complete and demonstrate a win, so you can show momentum. Change fatigue often sets in when you're asked to change and you're not seeing effects. But running these types of efforts and actually demonstrating impact and showing that things are now better for your patients, for your staff, for the system, can actually be very energizing. So the approach that we use is focus in on 2 or 3 areas at a time, set up a limited number of teams, have them focus on something that where they can demonstrate success pretty quickly, and then move on to more challenging areas. So in sequencing sort of the device choice and trays, as an example, you probably want to focus on the trays first, because there's some simpler, quicker wins that you can go after there that will be felt by the entire organization. The standardizing your joints is actually a very difficult one, and can lead to more contentious discussions. The final thing I would add is, once you've got a team that knows how to do this, the skills on those teams are very transferable. So some of the staff, either you can move some of the staff from the first team onto a new team that's focused in a different area, or knowing what you're going to tackle next, you can bring a couple of people onto the team from the next area to be part of the first team, so they can learn about the process and then transfer those skills.
Okay, great, thank you. We have time for a few more questions. So what DRGs most commonly demonstrate high variability?
So on the surgical side, I would say commonly 470 is the major one, so that's joint replacements. also DRG 460 and other DRGs around that area, which is kind of spinal procedures, and also general surgical procedures, DRG 330, which looks at GI operations. And as I said before, that's primarily focused around clinical products. On the medical side, we will commonly see septicemia, DRG 871, and clients will often, that's a specific subset of septicemia focused on septicemia with major comorbidities and complications, but clients will often look to group DRGs to work on, so looking at the whole septicemia pathway. Others will be pneumonia and heart failure, the ones that we commonly see showing significant amount of variation in medicine.
Okay, thank you. This question is for James. How do you go about engaging independent physicians?
So by independent, I'm assuming that we're talking about not employed, not part of a major group. And it's often, and I'd certainly defer to my colleagues here, but it's often the same sorts of drivers that would get any other physician to be involved. Whether or not you're employed or not employed, it gets back to what Eric was talking about, is what's meaningful to you, and for a group of physicians to be able to sit around the table and be a part of a conversation about how they want work and care to be done in the place where they do the majority of their work, is often, just having that seat at the table can be an incentive in itself. Once people understand kind of the importance of it to the organization and the importance of that physician to the organization. But what do you folks think?
I think that's right. I mean, the challenge is that often hospitals perceive independent physicians, especially surgeons, as sort of a risk of moving their business elsewhere if anything comes along to change the way that they provide care. I think two things in your favor. One is, again, getting back to understanding what's important to this physician and understanding if there's any part of this that actually helps. What we find is that often, especially if you look at device trays and preference items, preference cards, people are very nervous about approaching physicians about it, but the reason that they have their device trays set up the way they are isn't because of careful thought and planning. It's just what happened to be early on and has stuck around. So there's a lot of these things that don't raise the ire that you expect it to raise. In other instances, you will have some contentious discussions, and the positive side is making sure that you build the rationale for the change in terms that are meaningful to the physician, as James said. Also in your favor, over the long term, these kinds of issues are going to be addressed by all hospitals. So the physicians won't be able to jump around from site to site trying to avoid the choices around implants. And at some point, it's in their best interest to engage in that process with one hospital and hopefully move towards something that they're comfortable with.
Yeah, I just lastly just point out that I guess physicians are inherently competitive creatures, and presenting them with robust data that shows how they're performing across a particular specialty, across a particular DRG, will oftentimes actually drive them to improvement, purely by the fact that they're seeing that there are X amount of physicians who are performing above them on a particular metric. So that's kind of important to remember.
Yeah, that's actually a good point. You can there's a lot of change that's driven just out of the competitive nature of doctors, and a hunger for data, I would add too. I mean, many physicians just they don't get to see this data, they don't know that it exists, and they would change their behavior if they knew what was going on.
Okay, well, thank you. I want to draw everyone's attention to the last slide you see up on your screen. Please join us again for Objective Health's next webinar, which will be held June 26th at 1 p.m. to 2 p.m. Eastern Time on Is Your Health System Healthy? Driving Long-Term Performance Through Organization Health. We look forward to seeing you again. I want to thank James, Eric, and Ben for their excellent presentation and for all of you who participated today. We look forward to having you join us again for future webinars. This will conclude today's program, and have a wonderful afternoon.